I'm Dallas Nelson. I'm a geriatric medicine physician, a professor of medicine at the University of Rochester. My main gig is to run a group of physicians that provides primary care in the long-term care continuum in 33 senior living facilities and 12 nursing homes, and medical directing those, along with other activities, of which I became interested in telemedicine because it's advantageous in this space. I thought I would give you a little bit of background on my journey because I've been at this. I just double checked my CV while I was on this. Since 2010, I've been trying to do telemedicine in the long-term care continuum. And so I'm going to kind of just share my journey and some of the things I've learned over time. But first, next slide. What I knew when I began with telemedicine is that telemedicine in the nursing home setting had been proven to decrease admissions to the hospital. And it was a study where they had 6 intervention homes and 5 control homes. Now, only in this holds true in my research too. Only the engaged homes that wanted to do it, had a significant difference in hospitalizations. And if you had about 180 admissions per year, it decreased them by 15 admissions per year. So that was a savings way back then of about $30,000 a year, and medical savings of $151,000 a year. So the net savings was, because of the cost of the program, $120,000 a year, for almost 180 beds, which is a pretty good yield. So I knew that this was effective in the nursing home setting. Next slide. So what happened is I partnered with an emergency medicine researcher on pre-hospital medicine. He wanted to do telemedicine and was thinking about doing it in my nursing home. And I was like, no, I need it in my assisted living practice. So my assisted living practice, we provide on primary care to people within their senior living facilities. And that has lots of advantages for the chronic care management. They don't struggle to get out. We can be there, and we more frequently and manage their chronic conditions more closely. But the problem with that is that if I'm not in their building, I'm in another building. And if they have an acute change of condition, I need a means of evaluating that. And we just published another article. My assisted living tend to send to the hospital to use the emergency department as an evaluation tool. And it's excessive. And I wanted to intervene upon that. So this is where telemedicine came in. We did a wheel and spoke method. So we kind of live in the center. Rochester's easy to get around and a very short commute. And so we would get a phone call into the office, and then we would dispatch telemedicine technicians to the senior living facilities. And we did real-time video conferencing and store and forward. And we were able to we only were able to do this during business hours because of the number of homes, the number of requests, and we just didn't get enough on nights and weekends to sustain the effort. So it was a pretty conservative estimate. So next slide, you can see that over time it kind of gained power, and we had a further and further decrease in transfers to the emergency department over time. Next slide. We had an 18% reduction in the intervention homes of transfers to the ED. And while didn't end up being significant, probably due to power, admissions were also decreased. Probably if you touch the ED, you're more likely to get admitted. And then next slide, in the setting of a dementia, it was even more powerful, so that it was even a 23% reduction in transfers to the ED. Then, so I thought, wow, I was younger then, and I thought, wow, I'm just going to be able to do this. Everybody's going to pay me to render this sort of care. And then I went around and pitched the idea to every payer in town without success for a period of 3 years. 3 years later, somebody came back to me and asked to do it, but they really did wanted to do it in the nursing home setting. So we did do it in the nursing home setting, and this did give the nursing homes a minor incentive for participating in telemedicine on off hours. But truth be told, it did not pay for the running of the program. They did agree, the payers agreed to pay the equivalent of a face-to-face visit, which, understand, before the pandemic, we were getting $20 a visit under other circumstances. So the demonstration project did make it more accessible to the providers to doing that. But then the pandemic happened. And so that program went away. There was no advantage to it any longer. We did tons of telemedicine in the pandemic, partially just to keep our providers upright, decrease the spread amongst our homes. And we found that without specialized equipment, without specialized training, we looked at a lot of foreheads and had a hard time seeing the legs and things like that. So we've gotten some provider-focused carts. But I'll go to the next slide. We're having a hard time getting traction. The infrastructure there is not quite there. We don't have we are asking an already stretched system of care providers, the CNAs, LPNs, nurses, to run the machines in our buildings. And that meets with resistance because they have a good number of other tasks to do. And then also the turnover in these nursing homes is extreme. So I could spend all my time training people to run the machines, people training to just turn them on. The other thing is that the real benefit now, our group goes to the facilities, right? And so we do use the telemedicine once in a while for acute change in condition, but we're pretty much present and next to the patient. So we're doing a pretty good job on a daily basis. Where we really want more action is in the specialist consultation, but the infrastructure is not built for that. This is not normal routine for any specialist to engage with these nursing homes. And all of the different specialists use different platforms. Some of them use Teams, some of them use Zoom, and I have to train all the secretaries on how to get, I have to prove them wrong that they too can engage in Zoom intermittently. But there's a huge advantage to the nursing home patient having access to specialists. Number one, our transportation system has blown up. We have a very, very few ability to move patients, and these patients are using medical transport just to see their specialists. So that pressure that we are taking away from people who could leave the hospital when we're asking to see the specialists. So there's the decreased transportation burden. There's also many of these folks are stretcher bound. The offices can't accommodate. There's a lot of difficulty in getting into their spouses, their families are fatigued, and they are canceling appointments that we need. I've blown up the phone and begged specialists to take my patient back because the family was so fatigued, but I really needed that opinion. Also, even though the telemedicine is an increased burden, what we are doing when we send nursing home patients to the specialists is often we have to send an aide with them away from the building to the specialist office, which takes away from our care force. So there's a huge advantage to keeping the staff near multitudes of patients rather on a one-to-one, and being able to do the visits in the homes. And we're talking about a lot of the cognitive specialties. We have a home that has, osteomyelitis, requires a lot of infectious disease management, but they're primarily looking at labs and other non-physical exam sort of findings. So we have a member of our nursing homes on our telemedicine group from the American Medical Directors Association. His home has a special arrangement with ID specialists to see those patients and get those long stay osteomyelitis patients out of the hospital. Those long IVs. I have a patient who is using ketamine for pain control. And essentially, I am making sure to set up a telemedicine anesthesiology follow-up, because ketamine is new to the nursing home and the nursing home doctors, and they don't feel comfortable taking those risks in their nursing home without strong support from the specialists to help them, because this is new. They've never done it before. This patient has been in the hospital for 3 years. And this has been their barrier. So just having that specialist input on a regular basis is critical to throughput for the hospital and freeing up important beds for acute cases. So, so we need a more standardized approach, and we need an easier approach with our specialists, so that they don't find it so difficult and confusing when they do have to engage with the nursing homes. And I highly suggest that the hospital systems collaborate together out to the nursing homes, because if the nursing homes will not be able to build it one-offs toward the hospital system. And I also believe that a telepresentation force and the funding for that telepresentation force is going to be critical to the success of the building of an infrastructure in the long-term care continuum, because the patients are not going to be able to run the machines themselves, get the critical pieces of information to the medical providers, and the the nursing home is too pressed for workforce. So those are some of my ideas, some of my experience, some of what I've learned, and I'm open to questions. I did see one in the chat that I need to look at.
And the question is about incentives that have been explored other than states with bed holding policies in skilled nursing facilities to encourage SNFs and other kinds of facilities to make telehealth available. So are you familiar with innovative work in some, I think of some of the state, Oregon, what have other folks done?
Yeah, and this is Kevin. I'll add to that question briefly, if I can. Yeah. Sorry, this is Kevin. Just what a great presentation, Dallas. Thank you. This is awesome. And thank you, Lori. I'm the vice chair of our Health Alliance at University of North Carolina. So we do all our risk-based contracting, like our ACO and our risk-based contracts with private insurers, et cetera. And I can imagine a world where, as providers take on greater risk, the incentives do start to build themselves in there for us to figure out how to make specialty consultations actually available. I can imagine that world.
The two-sided risk, right?
Right. I mean, because at the end of the day, right, like, it's expensive if it's not good for the patient. I'm a doctor. That's what's most important. But it's also, risk-based care, value-based care does begin to provide incentives on the provider side for making some of these programs available. But gosh, as stretched as skilled nursing facilities are, like, how are they incentivized to participate on their end? Because at the end of the day, if the resident stays at the skilled nursing facility, it is indeed more work for the skilled nursing facility, and they're stretched. And so I wonder about, like, if there's even a disincentive to participate, and would just be grateful for any thoughts on that front.
I do think that at the moment the incentives aren't fully aligned on any side, the nursing home side, being that the nursing homes have been devastated nationwide already in the pandemic for staff and all of that. And then the hospital side, I don't know of any. I think there are payment models, but none of them are large enough, to my knowledge, to really incentivize changing the way care is done. They're all one-offs, one little programs. When I did the demonstration project and only one single payer came to the table and was willing to work with us, I wanted to expand it so far that I made my providers payer agnostic, so that we would at least see how far we could push this, even though we did, because I want it to be the way things are done, but it's not big enough to make it really the way things are done.
No, just in Geisinger, we actually, the hospital system itself would send out presenters to the SNFs, and and to coordinate it, because we had the exact same struggle. And the reason it was worth it to us was because we, really struggled to get the non-emergency transportation to discharge patients. And so, and a lot of what those services were being used for were transporting SNF patients to physician appointments that could have been done via telemed. So that was kind of the incentive in our case for the hospital to actually kind of step up and fill that role.